brief slideshow. A lot of these materials were developed by ODADAS, Director Orman's group, and he used these a while back at some presentations he did. I thought they were quite effective. These are some of our funding streams. So David, go ahead. Okay, this was a slide of the number of opiate-related deaths. As you can see on that curve, it's escalated dramatically, 300%. This also came from the Ohio Department of Health. This is the distribution rate of prescription opioids in grams. This is the amount of the medication being prescribed in the community. As you can see, it has a very steep curve, very similar to that first one. Next. And this is a correlation between fatal drug poisoning and the distribution rates of prescription drugs overlaid. And I'm not much of a science guy, but Director Hall says this is a pretty amazing correlation. I think it kind of speaks for itself. This is the ACADA admissions rate. Not quite as fancy as their graph, but it's getting there, you know? So this is the admissions that are from real information we submit to the board and to the departments. And you can see it has also a very similar upward rate, meaning more people presenting locally with this problem. Okay, next. It became the leading cause of accidental death in Ohio. Next. To give some, kind of comparison with the crack epidemic, although it was, had very, harsh problems for the users, you can see as far as comparing the amount of deaths, it was really very minor compared with the overdose on opiates. This just shows the ranges of how much of a problem there is by state. I found this from another source. And luckily, we're in the mid-range, but that's still bad enough. Next. I found this, and it's kind of interesting because when you're in a treatment program, treating people, it seems like drug addicts are everywhere, and there just must be a billion of them. But in reality, those who misuse prescription painkillers are still a relatively small amount of the population. Although a lot of people are taking the painkillers, the ones who are actually misusing still are a fairly small group with very severe problems. Next. And this gives a comparison between the amount of medical users versus non-medical users. Non-medical meaning they're using for some reason other than a medical problem. Now this group is very large, which this shows that there are a lot of people using or misusing, but it distills down to a much smaller group who become completely different. Next. This also came from Orman's department. I thought it was more than striking. In Ohio, in total, the amount of doses per person, so dividing all the population down to the number of doses, is 67 doses per person. In Ashland, we're blessed to be a little lower than that. We're at 45, but and some of the other neighboring counties are higher. But I thought that number was just rather amazing. Somehow, I'm not real good at numbers, but that one really sticks in my head. 2,392,961. 45 doses per person. And many of you in this room haven't taken one this year. So that means somebody's taking very significant amounts of painkillers. Next. The other thing is so many of the other drugs are primarily sold by drug dealers, but I've gotten something similar to this from several sources, that the major source of painkillers, pain pills, really come from others, from people who actually have a prescription. It may not be, the person taking the drug, it may not be their prescription, but somebody has a legal and potentially medically needed prescription. So they get it from friends, a certain amount get it from doctors themselves, or they buy it from a friend or other sources. So as a traditional drug dealer, you know, kind of hanging out someplace and selling and, you know, that sort of thing, it's relatively small for prescription painkillers. It doesn't go for heroin, of course, but for prescription painkillers. Next.
So if I'm reading this right, you're better off going to a friend and relative rather than a drug dealer to get your...
Yes.
Yes, okay.
More accessible.
Sure.
More accessible. Unfortunately, it doesn't mean it. Okay, this is a slide showing admissions for opiate abuse and dependence in 2001. And as you can see, it's pretty much centered in a few counties, largely urban counties, except for Scioto County, which is a whole different story by itself down there in Portsmouth. Next. This is in 2003, and I believe this is based on admissions to programs like ours. As you can see, there's a spread going on that kind of, an epidemiologist would say, it starts and it kind of diseases itself or spreads out. You can see the adjoining counties from the original counties are now becoming part of the problem. Okay, next. Okay, now 2005 kind of speaks for itself. It's really spreading, and you notice that now Richland County is red. Okay, next. And it'll be this last one, 2007, and now Ashland County is part of that. Now, again, this is partly based on admissions. I would think one reason we probably read a little faster there was that we started treating more people than maybe some other counties. Next. And there's the final. Now you can see all the programs in all the states are really admitting at quite a high rate. And probably some of the ones that aren't, probably just aren't really treating people very much. Next. Okay, now the correlation with property crime. We can see another very similar graphic. Next. This comes from Fairfield County, that's Lancaster, right? This is where Orman Hall used to be the board director down there, and they started looking into how many people are we dealing with in the court system that have opiate problems, particularly in the jail. And you can see what happened there over a relatively short period of time. Most of jail space began to be taken up by opiate users. Okay, so the goal is to reduce or attack the opiate epidemic, reduce addiction, drive pill mills out of the state. There's been considerable progress. There used to be places that were really kind of legal drug dealers operated by doctors, prosecute drug dealers, improve supports for opiate addicts, lower opiate overdose deaths. Next. One of my things that I think that is maybe the low-lying apple for this is to prevent diversion. And as I said, most of the medications are coming from actual prescriptions. So if people, begin to know how important it is to use them only as prescribed, store them properly, and dispose of the unused medications. The sheriff has been doing for several years now a drug take-back. I think that's wise. A lot of the source of this is medicine and medicine cabinets. People use part of their prescriptions, don't use them all, put them in the cabinet, somebody snacks them and sells them. They can sell for like $1 a milligram. So some pills can sell for $20 to $30 a pill. Next. Okay, these are some local goals that ODADAS has had. Treat higher number of addicts, use medication-assisted treatment, maintain increased capacity, coordinate opiate treatment with courts, probation, doctors, children's services, include opiate information and prevention efforts, increase public awareness of risk and levels of problems that exist. Okay, you'll notice I use the term medication-assisted treatment. We have other programs that You have some information about the jail program. It's really something we're very proud of. In fact, we're going to have the director down there for a visit later on. And we have some prevention activities we have in the county, but I won't focus on that at this point. It's going to be the MAP program. It kind of is like a story that relates to what we saw there. In the early 2000s, we started seeing more people coming in with opiate problems. Prior to that, it was relatively rare. We, 1998, somebody called from Transformation Network. We have a heroin addict. What do? I said, send him over. The guy never showed up. Just hit and miss, problems, but not really very significant. Some people had used opiates, but it was just one of their drugs. But really just didn't see too much. But more and more started presenting, as you saw on that admission slide. And we were a little bit mystified with what was going on. At first it seemed to be mostly pills. And what I would say is that clearly the amount of painkillers in society was the genesis of the heroin opiate epidemic. That many people that do use opiate painkillers and heroin, in my experience, had earlier histories of drug use. There might have been periods where they drank too much. There might have been periods where they used cocaine, they got away from it. So I think it was kind of an addiction trend based on supply and availability. The society, for whatever reason, was flooded with painkillers. I have ideas why that might be. Some people think it might have to do with the campaign to more effectively treat pain. You remember the little graph you get on your hospital now, like where do you put your pain? And that was probably valid in some ways, but I kind of think that gave doctors a big signal like, we got to treat pain better. We got to get out there and treat this. I think the relentless marketing of drugs on television and other places, I think kind of got society moving more towards an openness of taking pills, and kind of freed up doctors to feel like they should do more with painkillers. But for whatever reason, the facts speak for themselves. You went from relatively small amounts of opiates present in the communities to very large amounts on shelves, in medicine cabinets, so it became available. So people who might be inclined to experiment with drugs or misuse drugs, they had this new opportunity, this large amount of painkillers available. I don't know if I have time to go through the whole process, but people who get addicted to opiate painkillers move on to heroin. And the reason they move on is because of the great tendency to develop tolerance on heroin. You develop tolerance to alcohol, but you only go from maybe like a 6-pack to 24-pack. Well, that's a lot of an increase, but it kind of tops off. It's not an endless tolerance development, and that's the way it is with painkillers. Once the person gets addicted, they are very sick and dysfunctional when they don't have the drug. So they have a tremendous incentive to at least take enough to function. A lot of times when they take enough to function, they look pretty normal. They can go to work, they can take care of their kids, they can do things. So they're in this terrible cycle of use, withdrawal, use, withdrawal, use, withdrawal, with ever escalating dose levels. The amount they used to use doesn't really work anymore. They use the 2 pills they used to take, they're still sick, they need another, so they use more. Okay, at some point, their sources sometimes dry up. They had a guy that perhaps had cancer, and they were getting most of the pain pills or half the pain pills, and that guy died. So now all of a sudden they don't have it. Or the cost escalates so high for the painkillers. Okay, so then somebody says, well, you should take heroin, or you should try heroin. This will make you unsick. This will take care of you. And then they're often running on the heroin, usually snorting it, and then after a while they find out that, well, these 2 bags I'm using that aren't really getting me high anymore, or don't even make me not sick, if I shoot it, I'll get more efficiency out of it. So then they move to the needle. So to me, a lot of the underlying heroin epidemic is really just a culmination, the escalation of the pill problem. Our early treatment efforts, I have to admit, were pretty much failures. You know, we have a relatively modest inpatient fund, and we can send people into inpatient treatment. So I would send people up there, and they'd be there 2 weeks, or I'd maybe really stretch it to 3 weeks, and they would get back. Some of them would use the first day back. Some of them would use maybe a month or 2 months, and for that whole 2 months, they just kind of like looked really like, you know, tense, and they weren't sleeping, and kind of like a fuzzy head and all sort of thing, and then they would relent and use. Okay, so I think the failure rate was approaching 100%. So when you have that, you're not very happy, and you start to think about, well, what are we doing and what aren't we doing, and this doesn't make sense. And I'm a little bit Scots-Irish, so I don't like to spend money that doesn't work, you know. So I'm sending people off for all this treatment, it's costing thousands of dollars, and it doesn't seem to be working. So I started hearing about this new form of treatment called medication-assisted treatment. And I had heard something about this years ago at some workshops, but it seemed to be kind of taboo in the sense that it sounded kind of like methadone, and I don't know if that's a good idea, and there's a lot of stories about that. So we kind of, you know, gingerly approached it, but I thought, look, when it's not working at all, you have to be ready to try something a little different. Our board was supportive of us attempting to try to start working with medication-assisted treatment. But at this point, there really wasn't much out there as far as trainings and other models and other programs. So we kind of started on our own, you know, tried to read up on it and started doing it on a modest level. Almost all of our early treatment were non-coerced people. They were voluntarily coming in for treatment, desperately sick, seeking help. So we kind of a little bit at a time started doing it. I must admit that, wow, I was kind of enamored with the possibility because it seemed like a, you know, like a panacea. Like, well, this is it, boy, this really works. People would come in being deadly sick, we send them to the doc, they come back like a week later, they're normalized. They're able to talk to me, they're able to, you know, start counseling, maybe be in a group and this sort of thing. So it just appeared to be really magic. What I found, what I should have known in the first place, is addiction is never quite that simple. It's a hard path for people to get through. There's ups and downs, there's failures, there's successes, there's backsliding and different things. So it was kind of like an experimental process. But then over time, ODADAS started having some workshops, and Dr. Perrin did a nice workshop, which kind of gave us kind of an overview of what it should be. And interesting enough, it was like some of the things we were starting to do were part of what was recommended, because it was a process of discovery of what worked, like pill counts, different things like that. You know, so we're looking at something that was failing 100%. The only other alternative was something that was completely unaffordable. If somebody got all the conventional treatments you could possibly give them, it would mean 30 days inpatient, it would mean 6 months in like a New Beginnings, and then maybe 6 months in a 3/4 way house with a lot of outpatient treatment, probably costing somewhere between $40,000 and $50,000. Well, that's just not going to happen today. So that's the other part of this type of treatment. Although there are some significant costs to it, it's like way cheaper than what it would take to do that whole other process. Okay, so we started in 2004. Congress had passed a law allowing this in 2002. What it does is it allows doctors to prescribe a drug called buprenorphine. And it's usually prescribed in a compound called Suboxone, which is buprenorphine plus naloxone. Buprenorphine is a semi-synthetic opiate, and the naloxone is a blocker, so if somebody tries to inject the drug, it doesn't get them high. So doctors had to get a training and get a waiver. I was lucky enough to get to talking with Dr. Richardson in Mansfield, who has an addictionologist certification, and he went ahead and got the certification. So he had the waiver, so we started working first with him. In the early days, the doctor could only have 30 patients. Now they've upped that to 100, but he chooses not to do large volume. And I think that's wise because he's supposed to be a little bit of a handful to work with, and I don't think a doctor doing 100, 150, or 200 really makes sense. So at first I was doing all the treatment myself because I was trying to figure it out and learn and kind of taking on that learning curve. It was kind of unclear as far as the department, what their thinking was. They would kind of have workshops once in a while, but never really said much more about it. And there was kind of a period of perceived ambivalence about, are we really into this? Is it a good idea? Does it work? So, but we went ahead and proceeded. Okay, so we were cautious and kind of a small program, and then over time we advanced. Eventually Dr. Doherty agreed to work with us. He had some experience with some of his patients where he had a desire to try to work with this too. How does it work? Okay, clients are screened and assessed. We don't have all of our people that have opiate addictions on this program. Some choose not to be in it. Sometimes they're in criminal justice system. They've been detoxed to jail. We think they have a shot at it without the medication. They're maybe working with Jim in intensive probation or Kim. So we feel like, we don't really want to go the medication route necessarily. But in fact, the majority of people are not criminal justice referred. So once they're screened, they're referred to one of our doctors. They initiate the medication. I thought I needed to talk a little bit about how the medication actually works. Okay, first of all, it relieves withdrawal because they get very, very sick when they don't have the painkiller or the opiates. So it instantly stabilizes them and normalizes them when they take it. It reduces the craving to use. Doesn't mean they don't ever think about using or even sometimes want to use, but they don't have that strong craving. It also blocks other opiates while it's in their system. When they're taking the buprenorphine, it loads up the receptors, and the doctor calls it sticky. And other opiates, if they come into the system, they cannot enter receptors. Therefore, while they're using, it's blocked them from using in their system. So this is a great asset too, because if they use it properly for that day, then they actually kind of have an insurance policy. If they get weak or they decide that they might use it, they really can't use. It's also long lasting. It lasts over 24 hours. It also does not escalate in the need for more. It's not tolerance producing. They don't need more and more like other opiate drugs. Okay, but best of all, the client is now able to participate in treatment activities and normal life activities. Our clients have a lot to do. They need to completely rebuild their lives. Probably number one, they need to avoid other users. When they're constantly needing the drug, then they have to interact with other users. Once they have the buprenorphine, then we strongly encourage them to disassociate themselves from all using people, which is no small feat. Be kind of like with tomorrow I said, I want you to disassociate yourself. Everybody you spending time with or having a relationship with. That's a big step. They have to learn new ways of coping and a lot of new life skills. One of the big issues is typically employment. They, by this time, have usually not so good a work record, not all, but a good number. And they're low on resources like automobiles and ways to get to work on time, and they're just not used to that sort of thing. The driving force of their life part of this has been that use cycle. Now all of a sudden, they're freed up from that, but it's a big step for them to get into the job market, get a job, and then be steady about going to work. They also need to repair relationships. There's been extreme damage to relationship with parents, to loved ones, to spouses, so there's a lot of work to do there. If they are on the medication through our doctors, they must do individual counseling, group counseling, and 12-step attendance weekly. The length of treatment overall tends to be long, 12 to 24 months. Dr. Parent says 16 months is the optimal treatment. Okay, so some of the issues that developed in the program is, we didn't have a lot of direction or guidelines or knowledge from other programs to be able to start this out. In fact, some counties just said they didn't really want to do it. some other counties, courts have actually been resistant to allowing people to have this sort of treatment. The other is provider doctors. Doctors have to be very much in the loop, monitoring the medication, drug testing. We send weekly reports to both of our doctors on how our clients are doing. This is essential there be close communication. You understand maybe in large areas, you know, say in Akron, they may have their own inside doc, and that really helps because that shortens the communication process. But it can be a problem in a lot of programs if the docs are not philosophically on board with the counselors as far as the medication really becomes a leverage or a tool or a requirement, a requiring factor to keep that person in treatment. It takes, as I said, it takes longer, at least 16 months. There are complicating factors that have to be dealt with. Some clients are dual diagnosis. That means they have an alcohol problem, but they have a pre-existing anxiety disorder or depression. That can really complicate recovery. There can be a history of trauma, traumatic effects in childhood, or trauma while being a drug user. You know, robberies and maybe getting beat up, or having to go to drug dealers, this sort of thing, where sometimes there's violence. Again, lack of job opportunities. Most people that get in recovery, I think the majority do not have a job, so it's a big agenda for them to get a job, get back into the workplace, have that structure that work brings to our lives, and this has been difficult the last few years. Transportation and housing issues are a problem. They also can be the inability to afford the medication. If there is no health insurance, the medication can be several $100s a month, and doctor fees. Sometimes family members will help out because even though they've been tapped in every way monetarily you can imagine, once they think there's maybe some real hope, then sometimes they will help with the medication. But that is a significant problem. Diversion. I think I wanted to say something about diversion. And diversion means medication going to somebody else other than the person prescribed. Without strong monitoring, the medications may be diverted because they have a cash value on the street. This is why we work hard to avoid that, doing drug testing in-house for the people in that program, and the doctors do drug testing, and sometimes they're at probation and they're doing it too. There is Suboxone on the street. I'm sure the police type shows up in the pockets of addicts. What it's primarily used for by addicts who are not in treatment is to reduce withdrawal, the same way it works with others. So they can't raise the money to go and buy heroin, so they go to somebody and buy a couple pills, Suboxone, and take it for that day, then they aren't sick. This obviously is not really helping their addiction, but there can be diversion if you're not cautious in your programming. The amount of Suboxone that is prescribed by doctors through ODADAS, I think I figured out it's like less than 1% of the medications being prescribed in the county. So it's not really a very large amount in total. There are also a significant number of people from the county going out of the county to doctors in Columbus, Akron, Cleveland, where they are prescribing the medications to them. I think those are at least in part a source of the diversion that's going on. There are people who will go to Columbus, go to a doctor, get the Suboxone medication, and divert and sell it, use it to get high, and then go back on the medication and go back to the doctor and try to test positive. So this obviously is not what it's intended for. I think some of the other out-of-county doctors are somewhere between naive and profit-making. But the other is a little weakness in the law. It only says that people, a doctor should be able to refer. It doesn't say they have to. So therefore, they aren't always properly monitored. The other to be a little more sympathetic to the docs, they haven't always had a partner in the communities to work under a Suboxone medication-assisted treatment program. For instance, Mansfield is just now at the center starting their program. So even if a doc wanted to refer somebody to get that form of treatment, some of the local communities weren't doing it. Addicts who are on Suboxone legitimately through us are not getting high. That the drug, since they already have a tolerance, all it does is meet their sickness and does not really make them high. And that's one of the advantages of it. They can detach themselves from the whole chemical feeling sort of thing. So when they're on a normal dose, they feel very normalized, not really high. It's also slow acting, so it lasts for a long time. We work on outcome measures. That's been something that everybody, all different systems are looking strongly at now. And so our outcome system is determined with three simple categories. Poor, speaks for itself, didn't work, disappeared, didn't come in for the counseling right, didn't show up, 2 or 3 months went by, they're gone. Some good, meaning periods of success, periods of normalcy, taking care of children, working in different things, but not perfect. Maybe some relapses, maybe some other issues, using some other kind of drugs or whatever, but at least clearly some good. And then the last category is good, which speaks for itself. This means primarily they did the way they expected, stayed clean most of the time, and were successful. So those 3 categories break down to about 1/3, 1/3, 1/3, which is kind of interesting because way back several years ago when I started this, I was kind of estimating without a real strong count, and I was saying about 1/3, 1/3, 1/3. It turns out that's been kind of a sustaining model or amount of the outcomes. But although that sounds kind of modest, I'll be the first to admit that, and we're always wanting to do better, that's way better than 100% failure. So it's promising, it's doing some good, but again, I don't think it's a panacea. So I think we need to continue refining the program. We have trained other counselors, kind of moved it out so we have more capability outside of myself. We need to keep continuing to improve counselor skills. We need to more tightly coordinate with the doctors. So I think there's a number of things still to be done. I think the word now is getting out to the doctors about the medication, about the overprescribing. They're being more careful. I'm getting a lot of word of mouth information coming back about the caution they're using. Many regular docs just aren't prescribing. They're sending people to pain management specialists. Better coordination and work with courts and probation. Law enforcement and the court system plays a big role in the treatment. The other is just to continue searching for what works clinically and then on a national level, scientifically, to look for different approaches. I think our field always has to be looking for better ways of doing things.